Our pleasure.
Okay, everyone, it is 1:01, and in the interest of respecting everyone's schedule, we'll get things started. Now you can't see me because I have moved the camera and now I'm no longer in view, but all of you are.
Oh,
But, so, hi everyone. My name's Stephanie Champion. You have seen me once before, for those of you who are joining outside the room, because I was in the December session, but hello again. Just admitting people as they come up. So just want to say welcome to everyone joining the meeting, and thank you very much for coming to our February session for the CHAP project. Oh, I can see a waiting room, but I can't seem to admit. Here we go. Admit. Okay, so I have got a bunch of slides to run through, but just to start a quick introduction, we have a guest speaker today who's going to be talking about one of the assessment tools that are being used in Module 1 of the CHAP module. So Stacey Radford is our guest speaker for today. So Tracy Radford is a clinical physiotherapist who worked in cardiac and pulmonary rehab for 30 plus years. She now teaches at Flinders University in the College of Nursing and Health Sciences, and bringing up the next generation of physiotherapists. And when I was looking for someone to present for today's session, I was told that she was the cardiac physio at Flinders University. So we're very grateful to have Tracy come and speak to us about the 6-minute walk test today. But I will just start the slides. Well, I'll share my screen so you can see the slides, and we'll talk to that. So you won't see a lot of faces in today's session unless you're in the room. And just to remind everyone, we are recording the session today. Please feel free to leave your screens off if you wish, and that might help with some of our connectivity issues. So I will just switch over to sharing my screen. Hold on, sorry, let me just try a different screen, like one that actually moves. Why won't you be big? I do apologise for the hold up. What is it that you guys can see? If someone can just
we can see the slides, Stephanie. We can, but it just slideshow.
Yeah. Let's try sharing that one.
There we go.
Okay, there we go. All right. Move that to one side. Okay, so can you see the one which has got 2 little people and their dog walking across the screen?
Yes, we can.
Fantastic. Getting things started. Okay, so we're from the Country Heart Attack Prevention Project, and just to there we go. To quickly acknowledge the land on which we are standing today, we pay respects to our all traditional owners of these lands, to those who under custodial law are charged with nurturing and protecting the country, and we pay our respects to elders past, present and emerging. Okay, why did you not move? I changed before. Guys, here we go. Why do you not move? Here we go. Yeah. Like it was always how it was going to go. Okay, so those of you who are as familiar with the CHAP clinical manual as I am, Module 1 covers a range of new assessments and old assessments which are used when first interacting with cardiac rehab patients. And so I have a list of the ones I'm going to cover today, and I've highlighted 3 of them as ones that you guys may already be a little bit familiar with. So we've got the 6-minute walk test first, because I'm going to hand over to Tracy and let her speak to that slide. But then I'll quickly run through the other tools, talking a little bit about where you can find the tool in the manual, the modules in which the tools are relevant for, and some information about what that tool is collecting, why we're measuring that, why that tool, what a good score looks like, what you should do, what you could do if a client got a poor score, and some extra resources. I can see an admit, but can no longer reach it for whatever reason. Okay, so the first tool we're going to talk about today is the 6-minute walk test, and I can tell you that it appears on pages 141 to 146 of the manual, and it is relevant for modules 1, 3, and 10. So I'll hand you over now to Tracy, who's going to just talk about the 6-minute walk test quickly.
Thanks, Stephanie. Thanks, guys, for having me today. Just a quick hello to Lockie Sutton, ex-grad of ours. Just wanted to clarify that I may be a bit hesitant because I sort of got the wrong end of the stick with what we were talking about today. So I wasn't quite sure who my audience was, and that's the first question you should always ask, isn't it? Anywho, so I have been a clinical practitioner for 30 plus years, and 20 years of that I did cardiac rehabilitation in the days when we didn't really assess patients terribly much. So I will start by saying I personally haven't used the 6-minute walk test in a cardiac rehabilitation setting, more in a pulmonary rehabilitation setting, and that's probably what I'm most familiar with. However, I have found a little bit of information for you that hopefully might be of some interest to you. Now, Stephanie also said that some of you may be offering cardiac rehab remotely or in rural locations. You're all in rural locations, but remotely as well. So I will say 1 or 2 things about what I think, whether the 6-minute walk test is appropriate for doing sort of distance, if you like. So you probably all know how it works. It's a very standardized test. It has, 4 pages of procedure as to how to do it. And as such, you can't muck around with it too much if you want to get really reliable results, if you like. It is responsive to change after cardiac rehabilitation. On average, with a meta-analysis, there was about 60.43 metres difference between before cardiac rehab and after cardiac rehab in a paper that I read. There's reasonable evidence for its reliability, in being able to repeat it. But the thing I suppose also to remember is that although it's a sub-maximal test, it actually also, by the time the patient finishes, they really need to feel they have walked as far as they can in that 6 minutes, including any stops that they need to have. So they're not allowed to run or jog, but they need to really make sure that they've done absolutely everything they could do or walked as far as they could within that 6 minutes. So whether that's doable or not in a sort of more distant situation without somebody sort of prompting them, because there are these sort of 6 levels of prompts about how you keep people going, is probably a bit questionable. Obviously there is a minimally, I always get this wrong, minimally clinically important difference that you need to be, so that you know that your program is working, if you like. And in cardiac rehab for coronary artery disease patients, that's somewhere between 25 and 33 metres, okay, with an average of about 30 metres. So they need to succeed, to get a better outcome from their 6-minute walk test after cardiac rehab by at least 30 metres to know that you've actually had some impact on them, if you like. The nuts and bolts of doing it is that as I said, there's this big protocol for how to do it with very standardised instructions, making sure that, and certain things that need to be measured. A lot of those were developed for COPD patients, so oximetry may or may not be relevant for your patients. A heart rate is, and you need to take that every minute or so, and usually a Borg as well, so just asking them how breath. The other thing is that if you want to set one up in your centre, if you haven't done this before, you need at least a 25-metre flat track with, minimum interruptions, if you like. And that's so that you don't lose time in turning around the corners repeatedly. And also, I know it sounds really obvious, but you obviously have to reassess. If you're reassessing them, you have to do it on the same length of track, obviously. I suppose, what's the point in a 6-minute walk test? What does it give you? It gives you functional capacity measured in metres, obviously. It can give you an assessment point for starting training. You can work your patients, you can work out the speed of that the patient was working at, and then you can actually use that to derive a training program if you want to. And we do that in pulmonary rehab for pulmonary patients as well. Obviously, there's a bit of a ceiling effect with a 6-minute walk test as well, because you can't run. So those who are starting from a higher cardiovascular fitness level may not show as much improvement, or may not show improvement at all because of the ceiling effect of this test. And what else was I going to tell you about? So really the reason that I've seen it used, so when I used to work at Flinders Private, we were associated with Ashford, and Ashford were just starting to use a 6-minute walk test, not probably a very standardised one, I must say, but anyway, a 6-minute walk test is in their initial sessions as part of the assessment. And what they did was use that, the improvements that patients got as evidence to support the efficacy of their program, and to so that the private health insurers primarily knew that the patients were actually getting something out of it. But that's really all it tells you. It's just a functional capacity assessment of distance covered. And that's probably all I need to tell you about, unless anybody's got any questions.
We might save the questions until the end, if that's all right.
Sure.
Oh, Tracy, are you happy to hang around until the
Yeah, sure.
Yeah, fantastic. Thank you very much for that, Tracy. And now I will take control again, as shoddy as my control has been, and we will move on to the next test. So I'm not going to attempt to say the name of this one out loud, but that score, CHAP, thank you, CHAP. It's all of those twos that were throwing me. So this is mentioned on page 41 of the CHAP manual, and it is relevant for modules 1 and 10, so it is a test and a retest. It's used to estimate 1-year risk of a stroke event. It's comprised of 7 items, and they collect information on age and sex, but most of the questions, 5 of the questions, are on medical history. And they're all in a yes/no format, and you get a score depending on the answers that you give. So research has indicated that it does accurately predict long-term risk of stroke, and it is free to use, which was very important to us, and it is designed to be self-administered. So it is easy for clients to understand, but also to complete on their own if they're completing it themselves at home. Scores range from 0 to 9 points, and a score of 0 is ideal. So this is very low scoring, but a score of 1 or greater would indicate that perhaps there is a need for a prescription for anticoagulation medication. And so if you had a client who got a score like that, it might be a conversation you want to have about talking to their GP about getting a script. And I have included a little reference at the end there. That is an online resource where you can go, and it's got a calculator, so you can put your details in and work out what your score would be. The specific activity questionnaire is on page 147, and it's important for modules 1, 3, 9, and 10. So this is something that we will like clients to come back to their score of. And so it's used for assessing functional capacity in people with cardiac disease, especially when exercise testing isn't feasible. So for those of you who could hear about the 6-minute walk test, it's not always going to be feasible to run it. And so there will be situations where perhaps this is the only score you have to get a reflection of their functional capacity. So it's a list of 13 activities and their corresponding METs, and they get consecutively more vigorous as they go. So it starts with something quite simple and then moves down to a quite vigorous, like marathon level activity. And they're all yes or no questions. So you're asking essentially whether an activity could be completed without having heart symptoms. So from a score from 2 up until 9, you'd see at what point people started saying, yes, that activity is a problem for me, and then that would be a cutoff. So there's no normal score. It really depends on each individual who's doing the test, but the value lies in the retesting. So when they come back to the reassessment that happens in module 10, you can have a comparison of the score that they've got. So research has indicated that even a 1 MET drop would indicate an improvement or increase survival, at least for men in the study that they did. But if you did get someone whose score was concerning, that might be a fit to refer them to an exercise physiologist or an occupational therapist via their GP. The nutrition questions, I think, are probably pretty straightforward and things that you have already seen before, but it is 7 items which collects information about their eating habits very broadly: vegetables, fruits, grains, plant-based proteins, if they use added salt or if they have takeaway on a regular basis. And each of those questions have some categories to go along with it. And there's no overall score for these questions, but individuals who say, oh, you know, I often have takeout, there's a little guide to go along with it in the module that says that might be an indication to have a conversation about not doing that. If there was some concern, then perhaps a referral to a dietitian might come out of that tool. In addition to perhaps the information that they get through their GP, we're obviously going to encourage them to visit sites like the Heart Foundation and the CSIRO, where they can get more information about what a good diet looks like and do a really in-depth assessment of their own diet if that's something that they're concerned about or that we suggest that perhaps they may value. The medical adherence questionnaire is for modules 1, 6, and 10. I think we're probably okay for the, oh no, we might want to have that for the question time. Yep. So I've got a tech guy here to help with some functional issues. Thank you, Andrew. Tech guy has a name.
So where's this on the menu?
So the medical adherence questionnaire is relevant for modules 1, 6, and 10, but we'll have to send you a list of questions.
All right.
Yep.
We have questions at the end.
Yeah. Yes. Yeah. Although, does that help for you guys? Would you rather have questions as we go through? No? Yep. I got a lot of ground to cover. Let me work my way through it. So the medical adherence questionnaire is collecting information essentially about medication taking habits and measures adherence with medication taking and behaviours around medication taking, and that's quite important. So the 4 items collect information on whether if they remember to take their medication, if they take breaks from their medication, if they accidentally skip doses and have done so recently, and if they deliberately skip doses. So this is more than just saying, are you adherent to your medication? This is trying to untangle why they may not be adhering to their medication. but it's done in 4 questions and they are yes/no questions. So really easy, straightforward, no judging, no probing about medication adherence. And it's commonly used as a self-report tool. So people will have no issues understanding what the questions are trying to get at. The scale is 1 to 4, and a point score of 3 to 4 would probably indicate low adherence with their medication regime and might suggest that that's a conversation that they need to have perhaps around their goal setting about taking the medication, or whether or not they need to speak to a community pharmacist, depending on what their reason is for their non-adherence. Go on. Now this one is one you guys are already really familiar with, so I don't know how much depth you want to bother going into for this particular tool. I've included it just because it's on the list, and it's on pages 149 to 150, and it's relevant for modules 1, 8 and 10. So yes, this is a screening tool for likely depression. It's not a diagnostic tool, but it does indicate likely depression. You already know how it's structured. We have sticking with it because it has high sensitivity to identifying individuals with major depression, and it has been evaluated to be diagnostically valid. It's designed to be self-administered. It is free to use. Scores range between 0 to 27, and a score greater than 9 would indicate anything above that would be moderate through to severe depression, and might indicate that you want to refer them to a GP or to other services to support them. The cardiac anxiety scale is from pages 151 and is relevant for modules 1, 8 and 10. Now this one is obviously specifically designed for cardiac patients. It's right there in the header. And it's designed to measure heart-focused anxiety, including heart-related events, sensation and functioning. So it is 18 items long, which is a bit longer than the other scales, and it measures across 3 subscales, so fear, avoidance and cardiac related sensations. All of them are scored on a 5-point frequency scale, from never to always. This particular tool has been evaluated to be effective at differentiating between cardiac anxiety and regular old anxiety. So it's particularly useful for this group who might also have regular anxiety, but you want to untangle that. It is designed to be self-administered, so it's quite easy to understand the questions. And you can get a possible score of 0 to 72, but you use the mean of this score in analysis. So looking at the scores from a 0 to 5, 0 to 1 would indicate low anxiety, and from 1 upwards, you're starting to get into the anxiety territory. And a score of 1.5 or higher would indicate a high level of anxiety. So if you did have a client who got a score above 1.5, that might be an indication that it would be helpful to refer them for further testing to see what is going on with their anxiety, if there's anything that could be done to support them. The EQ5D, is this one that people are familiar with? No, okay, so this one is all over the internet. It is free, and they work really hard to encourage people to use this tool. And I've seen it used in a couple of studies that I've worked on. So you can find a lot of information about this particular tool online. So we will share the resources so you can see the entire history of the development of this tool. But the EQ5D5L is one of the more latest renditions of this tool. It's on page 152 of the manual, and it's relevant for modules 1, 8 and 10. So it's used to collect an individual's self-judged measurement of their current health status. It is a tool that's often retested. So you'll get a score and then you might retest a couple of weeks later or a couple of weeks after. So it's quick and easy, like 2 minutes for somebody to do this test. So it might be something that people want to do multiple measures of. There's 6 items in total. The first 5 cover dimensions of mobility, self-care, usual activities, pain, discomfort, and anxiety and depression. And they're all measured on a 5-point severity scale. And then the last item, which seems wacky to me, but it totally works, is a measure of their health status on a scale of 0 to 100. So where would you put yourself today on this scale of 100 points? And they can choose any of the items along that scale. It is commonly used, and it was used in the South Australian Health Omnibus Survey. It's free to use and it is self-administered. So the responses on the scale are transformed into a 0 to 100 point score. But really, the EQ5D5L is a population measure. So it has more use to us, perhaps, than to an individual person. So they might want to use their scores for a test or retest scenario, but you as clinicians don't have to worry about judging whether their score is high or low, because it's just one day. And there are other tools that they will be undertaking, which would give a bigger picture of their health. The Brief Health Literacy Screening Tool, called Brief, which is very helpful, is on page 153 of the manual, and it covers modules 1, 2 and 10. So the reason for this tool is to measure the capacity of individual patients to access support and to understand basic health information. So it's only got 4 items in it, but it does cover what can people understand, what can they access, do they know how to seek out information, do they know how to fill in medical forms. It has a similar sort of sensitivity and accuracy as much larger tools, which is why this one was selected. It's only 4 items long, and it is designed to be self-administered. So scores range from 4 through to 20, and a score of 4 to 12 would indicate limited health literacy. So there's 3 groups: limited, moderate, and satisfactory health literacy. So clients with low health literacy, you might need to guide them towards resources that are more focused on providing illustrations or videos to convey information, and the CHAP website will be a place that you can send people to get information about cardiac-related health. And I have provided a little link there, which is to the Brief tool, which is available online, so you can go and fill it in yourself. The KCCQ is actually not called that in the book. It's called the Minnesota, what is it? It is.
Living with heart failure.
It's the same questions, essentially.
Minnesota, MLWF.
MLWFQ.
Okay.
Yeah. So sorry for the slightly confusing labelling of this particular tool, but this is the 12-item version of, and it includes much of the same questions as those two. So I'll steer you towards this one. There are 12 items across 3 domains and are all scored on Likert scales. It's been validated, it performs as well as larger scales, and again, it has been designed to be self-administered. So responses on the scale, responses to the questionnaire will be scaled to be a score from 0 to 100, and a score of less than 50 would indicate poor to fair health. The score of less than 25 would indicate poor health. So again, the greatest value in this test is the retesting of it. Did their health change between week 1 through to week 10? And a change of even 5 points in that 100-point scale indicates a clinically meaningful improvement. If the change is up, if the change is down, same sort of situation. So this is very sensitive, and it will pick up on small changes in people's well-being. The arterial fibrillation severity scale is on page 156 and 157 of the manual, and it refers to modules 1 and 10. And so this is looking at, this is specifically for the arterial fibrillation patients, won't go to everybody, and it measures both the frequency and severity of symptoms, and then the impact that those systems have on overall this tool has been evaluated for validity and reliability, and it's been specifically designed for arterial fibrillation patients, and it has been designed to be self-administered. So this is a tool where there's no scale. Each individual question is meaningful. So if you have a look at the manual, you'll see against each question there is a ideal response. And so if it deviates from that response, and usually it's a case of, oh, you should score lower or you should score higher on this particular item. So it's a conversation starter as opposed to a here's a score that will definitively put you into a box. But if you sort of came out of that tool thinking, okay, this particular client might be having some issues, that might be an indication you want to refer them on to a psychologist. The stop bank questionnaire is the last one, and then I can stop drowning you in information about tools. But the stop bank questionnaire is one you're familiar with also. Yes. So it's on page 161 of the module, the manual, and it covers modules 1 and 10. And so the only thing I'll add is, I don't know whether you're aware of what a good score or a bad score is on this scale, but a score of 0 to 2 indicates a low risk of obstructive sleep apnea, and a score of 5 or higher would indicate a high risk. And I have included a little link to that particular tool for anyone who is unfamiliar with it, and you can have a go at it and see how you score. Okay, so I'll just leave it at that screen before we get into the goal setting, and just ask if people had questions about the tools that are going to be used that are raised in the manual.
Can I just give a bit more background?
Yes.
So a lot of work went into putting this together, and there was some basic principles for the standardization of data collection. One of the principles was the shorter tools were ranked higher than the long 100-question tools, and that tools that were free were ranked over tools that you had to buy a license for, because that's people have no idea that rehab services don't have any money to pay for things like tools. I mean, no. Oh. I mean, the chair is a much higher ranking than so we get that. And we also we are working with Syslinks to get the whole thing loaded up into an app, so that there's no data entry or paper. You just bang on the screen, you know, and you don't even have to write text. You can just drop down boxes and make choices for the questions. And then behind the scenes, Syslinks are going to do some decision support to get the scores, and then send you back a feedback loop, or the patient, what the scores are, what they mean, and if there's actions, just as like a reminder system. So that's entered into their notes. So that's our big picture aim. We've really worked hard in consulting with all the experts, and when I saw the Kansas City, maybe she was like, yeah, no, the Minnesota's got the license. The Kansas, which one is?
One has a license and one doesn't. So Kansas City has a license.
All right, so that's important, but it's got a new short form, and I just remembered to text as Andrew Driscoll, because she's setting up a registry for heart failure nationally, and it will be pretty much which one they decide goes into the registry, which one we should go with. So we'll get Victoria, yes, we'll get an expert opinion on that. We went to CSIRO, and they had these tools that had 70 questions with it. So then we went to Heart Foundation, and the 7 questions are basically 5 vegetables, 2 fruits, junk food, soft drinks, you know, like a scan of healthy eating, not right down to how many chickpeas and legumes do you have, and blah, blah, blah. So we just thought a really simple score. And as Stephanie just said, that's a yes, no, and really just looking at that. Interesting stat is 95% of Australians do not meet the 5 and 2. So
Yeah.
you already know what the answer's going to be there, but you know, it just helps collect, you know, standard information. So I think with the 6-minute walk test, that's probably more for the face-to-face guys. There is the alternate tool. So there's two there. There's one that's reported, as you said, the marathon one, and the 6-minute walk test. Maybe we can get patients to do their own 6-minute walk test with mobile phones or Fitbits or something. So we'll see how we go when we go with the activity monitoring. So I think the next step for us, once Syslinks has got it all on an app, we're going to play with the nursing students up the hill and time ourselves and have some data about how long it really does take to go from low to go. And then if it's ridiculously long, it won't fit in our business model, so we'll have to cut it. We'll have to have a conference, you know, we'll have to a collaboration and say, okay, what can we do to reduce this, or different ways of doing it. So, but at the moment, it's very popular. People are interested in the fact that we've covered all the risk factors, and we've got a tool that matches them. And then we're, at least in CHAP and probably in South Australia, we'll have this whole standardised data collection, which CHAP was already, you know, doing anyway. There's a couple of new risk factors which I'm really pleased to see at the Heart Foundation, and that is menopause has been recognised as a good risk factor. Yay for the girls! And it's not good news, but it's just recognition. And the other is cancer therapy. So cancer therapy is toxic to the heart. So it's a good question to ask you, have you had cancer treatment, and are you in menopause? Someone I was talking to about that the other day with the health literacy said that might lead to a whole education about the birds and the bees, but that's okay. It's important if women don't understand menopause. And health literacy we are focused on because we're in the website business, and so one of our plans for the CHAP website, the Catch website, is we'll probably have no words. It'll all be pictures and videos, and you don't need to be able to read to be able to get the messages, and animation, so it's less intimidating. So health literacy really affects outcomes, and we're just talking about a grant that we're doing, and health literacy seems to be the tipping point for so many things.
So I mean, what Robin essentially has said is that the point of these tools is that they are fast to run, that they give accurate results, that they let you know whether there is an issue, and gives you a starting point for a conversation if you need to direct a client on to further support, whether that is identifying the fact that their health literacy is low, and that should always be taken into consideration when you interact with them, or, you know, that we need to create resources to support those sorts of clients.
And I was looking at Susie, you know, Susie when she was here, she was in the background, and I just found a spreadsheet of hers. She contacted everyone through ACRA all around Australia. What tool are you using for depression? She's got ticks in these columns. What tool are you using for medication adherence? So I'm really confident now that we've also aligned ourselves around Australia, not just SA. So that's good. I feel confident about what we've chosen to do.
So does anyone have any questions about the specific tools?
I do.
Yeah.
Oh, yeah, no, just with the cardiac anxiety scale.
Yeah.
With HQ9s, you there's capacity to do retesting along the line, like you do it at, you know, completion and blah blah blah. Is that something that you would do with the cardiac anxiety scale as well? If they scored high at the start of the program, would you then retest it?
Well, you would be embedded into the system with retesting at module 10, but that is weeks and weeks later. So that might be a conversation that you want to have with that particular individual and ask, you know, is this something we want to be revisiting? So the cardiac anxiety questionnaire scale does come up again in module 8. So that might be a time to revisit it and go, okay, so that score that you got, depending on how long it's been since they originally did the test, do you want to go back and do a retest? And so we want to make sure that there's a facility to do that in the system.
So that PHQ9 is a protocol for retest. It's in the protocol. We'll have to look it up for anxiety. So if you get a high score, what's the time frame for the retest?
And the 0 to 100 scale for the quality of life tool,
Yeah.
is that, can that be added to the number? Because 153, it says mark an X on the scale to reflect how your health is today.
Yep.
Please write the number you mark on the scale in the box below.
Yeah.
Where is that?
So the EQ5D5L is normalised against UK scores. So the process by which you spit out a number at the end, this is why it's not terribly useful for individuals. It's more of a population measurement. So for that particular score, it might be talking to the client about, hey, you gave a 75. What's going on with you that gives you that score, rather than there's a cutoff at which we want to start that conversation. So that's a beautifully grey area and will depend on each individual. But we can provide more information about how that tool is calculated, which does lead me to one of the thoughts that we had was to provide a cheat sheet for all of these measures, how they're measured, what they're measuring, how they're calculated, one-stop shop to add to your manual, where you can just say, oh, these are the tools and this is what they do. Is that something that would be helpful? So I just sort of ran through at warp speed with all of the information I found. So yeah, we'll provide a table.
So it was my idea, because I find the current format very frustrating, because it's bang and it just, you don't know what's next, you don't know what's coming, you don't know when it's going to ever end. It's not, it should be one tool per page. It's, you know, like economic, you know, like so that the brain stops and, you know, you're going to the next one. So I think we can do a draft tool reformatting and having a cover sheet that's got the risk factor, what tools going to be used and what the results mean, just as a quick, and the order that you're going to see them in this,
Yeah, and maybe some suggestions for places you could send the client if they want more information online.
Yeah, referral,
I think that's probably, because quite often we are the intervention as well as the assessors.
Yeah.
So, I mean, I think to say that we're just doing the assessment in isolation is probably not realistic. Often we would do the assessment and use that as a vehicle for our intervention. So I think if they're useful to prompt us, have a dialogue, then they're great. But if they're like, that's a lot of assessment tools that realistically in practice I would not use all those when talking to a patient. So if we had them before us, we have to pre-assess the patient on which assessment tools we should use, and then use the assessment tools to then intervene. And often a country patient will then not go on to see a psychologist, so we have to provide the best intervention we will be able to. So I think the sort of next phase of that is when the assessment tool spits out a worrying result, are we happy to just leave it with refer out? Because I mean that's not really what we do now. We discuss and we counsel and we support. So I would fear that we would remove intervention time for assessment tool. You know, if there's too many and they're too lengthy. Yeah. Is that a reasonable comment?
Yeah, we agree. We agree.
Like how we can judiciously, but really like
you want to be efficient.
Efficient and judicious with the use, but so you drive the conversations and then have a straight answer as to what to do with that.
Yes, so that's something we will include with our cheat sheet, is some suggestions on where to go next. Are there any other questions from the group? Because we've sort of run out of time, and I don't know whether it's worth going too hard into the SMART goal setting. Is that something that people are already pretty familiar with? All right, I can cut it off there, but coming back to the group, so I'll stop sharing my screen. So coming back to the group, did anyone have any questions for Tracy about the 6-minute walk test? Oh, we have a chat.
We could do it.
Just I'll go and find some videos to put up with this week's lecture. And there's a whole lot of clever videos, like how to do it anywhere, you know, at home in corridor, and you just need this and 2 chairs, basically.
That'd be cool.
Yeah, so we'll get some thoughts out there for a creative. And also, I don't know if you've met Hoy Du, one of our colleagues from Sturt. She did a whole PhD on self-assessment 6-minute walk test for heart failure. Yeah, so she had patients going around their corridors with mobile phones and things. So she's an expert in that.
I'd be interested to read that because I've always maintained that 6-minute walk test remotely is not a safe thing to do.
Yeah, that's
Well,
what
it
I
is
was gonna
included
say.
in the protocol.
Our
Yeah.
exercise physiologist, Chris, but we've had this conversation a lot with him, and it's where do you stand from a safety point of view? Like, we haven't laid eyes on these patients. We have no idea.
Of the engagement, their
Yeah,
balance.
and that is a real challenge for an exercise physiologist doing telephone rehab, but I just don't know.
When your
Yeah.
guidelines, sorry, not to continue, but when the guidelines state, you know, you need
To have a professional
Pulse-
on hand.
pulse oximetry,
Yeah.
oxygen, you know, you would have to
Right,
be very
mm,
careful
yeah.
with duty of care lines.
Sure, we can get copies of that for you.
That would be good to read.
That'd be
Yeah.
paper of the week.
Yeah.
And to our online audience, any other questions? No, it's a bit quiet out there and we have run out of time. We're happy to leave it there for today. Okay, so thank you very much, everyone, for coming to our first session of the year. March is going to run technologically smoother.
Yes.
But thank you everyone for sitting through that. We will be in contact with the group. We'll do a follow-up email just to let everybody know when the recording has gone up and also to share tools and stuff that we've just talked about here. And yeah, everyone to
See you next month.
see you next month. Great. Thank you very much.
Thanks, Stephanie.
Thank you, Tracy, for joining us today.